Good evening, all, and thank you very much for joining us for our seminar for the African Research Group at the Center for Trust, Peace and Social Relations, Coventry University. Today, we are happy to have Dr. Luisa Enria with us. She is an assistant professor in the Department of Global Health and Development at the London School of Hygiene and Tropical Medicine. Her research draws on political anthropology to study violence, humanitarianism, health emergencies, and knowledge production in epidemic preparedness. Her PhD research at the University of Oxford Department of International Development focused on experiences of unemployment and post-war political violence among young people in Freetown. She currently works on a number of projects looking at community experiences of epidemics, preparedness, and biomedical research in Sierra Leone, including conducting ethnographic research with the Ebola vaccine trial, a study on the political economy of vaccine deployment, and a social science training for community health workers to explore vaccine confidence and experiences of COVID-19. She currently holds a UKRI Future Leaders Fellowship titled Crisis of Confidence, the Politics of Evidence and Mistrust in Epidemic Responses. Thank you very much, Luisa. I'll now hand over the floor to you for your presentation.
Thanks so much, Zainab and Jessica, for the invitation. I'm really excited to be with you guys today. So what I'm going to do today is to talk you through the experience of an ongoing collaborative project between myself and our colleagues at the Cambia District Health Management Team in the north of Sierra Leone. And I'm going to focus quite a bit on the kind of practical aspects of setting up this community-led ethnography, which initially focused on vaccine confidence issues and then more recently on COVID-19. But as I'll kind of flag up throughout the discussion, a lot of the concepts that I'm using and a lot of the issues that we're engaging with are also kind of conceptually, I think, contested. And what I'm hoping that we can do also in the discussion is to kind of think about how these new approaches to methodology that we are trying out in Sierra Leone by doing trainings and community-led ethnography might actually help us to rethink some of the key concepts that are involved in the way in which we think about epidemic preparedness and response from a social science perspective. So I'll focus on the practicalities, but I'm very happy to kind of think more critically in the discussion about some of the theoretical inputs as well. Okay, so what I'm going to try and do in the next sort of half an hour or so is to kind of situate the project itself and this kind of idea of community-led ethnography in broader conversations that have been going on, or at least some that I've been involved in since the West African Ebola outbreak in 2014 to 2016. And kind of situated in these discussions about the role of social science in epidemic preparedness, and epidemic preparedness being kind of broadly defined as a range of activities from clinical research to vaccination and epidemic modeling and so on, to prepare for and respond to different types of epidemics. And so I kind of want to situate this particular research method in these discussions about where social science sits in these sort of infrastructures for preparing for epidemics in the future and the present. And then I sort of think about what kind of challenges have emerged through these discussions about the role of social science in epidemic preparedness, and then think a little bit about how these, and kind of talk you through how this project emerged really directly in response to how we experience these challenges on the ground in Sierra Leone, and how we kind of thought through how difficult it actually is in practice, however kind of nice it sounds in theory, to integrate kind of social perspectives in epidemic preparedness and response. So I'm going to sort of talk about a little bit about the sort of substantive findings. So what the community ethnographers that we trained found, both about vaccine confidence and their experience of COVID-19. But then I'll focus a little bit more about the lessons on process. So what have we actually learned about how we produce knowledge about epidemic preparedness in this way? So the origins of these discussions are to sort of situate where these kind of conversations about the role of social science in epidemic preparedness comes from. We have to sort of think back to the Ebola outbreak that affected Sierra Leone, Liberia, and Guinea in 2013 to 16. And I think this narrative is probably familiar to many of you, certainly to you, Mustafa, considering what you've been telling us about what you work on. But I'm particularly interested in kind of thinking about how, especially at the beginning of that particular epidemic, there was a lot of discussion, a lot of thinking about what role the concept of community played in how we understood the way in which the epidemic itself was evolving, and in general about how we think about epidemic control. And so in that context, the communities, at least at first, were kind of conceptualized as a problem, and culture in particular kind of thought of as a barrier to effective interventions. And I mean, I think this was particularly obvious when we think about safe burials, for example. There was a lot of discussion about how kind of culture and tradition was making it difficult to develop effective interventions. So that the kind of language was around resistance and behavior change and so on. And so at that point, there was a mobilization that at the time was sort of, sort of unprecedented to some extent in terms of its size and funding, and certainly has not been quite replicated since. A mobilization of anthropologists who had been working in and around the region, and that were sort of initially critiquing the existing response and particularly emphasizing the importance of contextualizing both the experience of the epidemic itself and how people were engaging with and understanding and perceiving what was happening around them in countries like Sierra Leone, but also Liberia and Guinea, but also how they were experiencing and thinking about the response itself. So these kind of anthropological research and kind of commentary emphasize the importance of considering history and political and social relations to focus on mistrust rather than resistance, for example. And kind of thinking about how we could engage more effectively with individual and collective priorities, rather than kind of, rather than seeing people's unwillingness or maybe inability at times to adhere to some of the epidemic response measures. And I think that actually, I mean, we can talk about this more in a discussion, but I think some of these discussions are much more familiar to all of us now that we've all sort of experienced an epidemic and pandemic response measures across the world. So I think drawing those parallels will be interesting as well. So these kinds of interventions, I think, sort of created some opportunities in some ways. So during the outbreak itself, it meant that there was much more of an opening to integrate anthropological, but more generally qualitative social science knowledge directly into response activities. And there were some initial efforts to co-design some programming. So I was involved, for example, in the Ebola vaccine trials, as Zainab mentioned, and I'll talk about that a little bit more. And there was a bit more of a direct effort to sort of think about community engagement, to move beyond sort of top-down communication and think more about dialogue. And I think sort of in terms of, to sort of situate what conversations this particular project I'm going to be talking about today, we need to think about what happened afterwards and what kind. And I think that the experience of Ebola in West Africa, in particular in the Mana River region, which was mostly affected, sort of led to this emergence or kind of proliferation of different internal reviews and lessons learned documents and so on that really emphasize the importance of building trust and putting community experiences and perspectives at the center of epidemic response efforts, which also meant advocating for more interdisciplinary approaches, more effective mobilization of social science expertise. And this conversation has continued over the last few years, and it continues today, unsurprisingly, with the outbreak of COVID-19. Although I think, and again, this is something we can discuss more later, I think it's actually been much less successful, I think, in terms of effective integration of social science perspectives in kind of global COVID-19 response. But in any case, the WHO last month or in March has kind of come out with this push for what they're calling community-centered preparedness and response. So really an effort to put kind of community perspectives and experiences and hopefully knowledge as well at the forefront of how we think about what epidemic preparedness is and how it should be done. But I guess over the years, what our teams and myself have been thinking a lot about is actually that whilst it's really important and great that the need for interdisciplinarity and community-centered approaches are being recognized, there are some challenges that remain sort of a little bit in the shadows, let's say, or a little bit unspoken in these pushes for, or in this kind of rhetoric around community-centered or community-driven epidemic response. And these challenges include, for example, that the actual difficulty of really integrating different disciplinary perspectives or different forms of knowledge, different ways of knowing and kind of being in the world. And the fact that this often happens, unsurprisingly, for an epidemic response field within existing kind of biomedical kind of frameworks to a large extent, and sort of specific hierarchies of what evidence is acceptable or seen as more truthful than others, let's say. On a more kind of practical level, it's also been quite difficult in some of our experience in Sierra Leone to operationalize or to produce knowledge that is seen as operationalizable by those who work in epidemic or in other aspects of epidemic response, like clinicians, for example. So just to give you an example, we were talking just now about mistrust and the importance that anthropologists pointed out in the West African Ebola outbreak of understanding mistrust as a product of a long history of extraction and expropriation, for example. But that's of course quite difficult to operationalize in the moment or in the urgency of an epidemic. And I think that also beyond that, there is a question of what we really mean by community-centered and what that actually looks like, and how those community perspectives are gathered, who produces community knowledge, and how that is then sort of translated across different spaces and then translated into different types of operations. And I think that different types of actors have different ideas about what community-centered means, but the truth remains, and I think we're all aware, I guess, also of the sort of structural constraints and sort of, I guess, epistemic injustice that continues in both research and practice fields, whether it's the humanitarian sector, whether it's the universities and so on, about who actually gets to contribute to producing particular kinds of knowledge in these spaces as well. So in practice, what this has actually meant is that whilst there has been, at least in my view or my experience, and more interest in kind of understanding community experiences, there hasn't been a huge amount of actual participation from affected communities or even people who are directly implementing epidemic response in practice in the field, for example, and actually producing some of the knowledge or doing research around sort of explicitly around these issues. So the main focus of the talk today is really about a project that we've been working on, as I mentioned, with colleagues at the Cambia District Health Management Team in the north of Sierra Leone. And the premise I want to sort of make before I talk about the specifics of the project is that I'm by no means sort of suggesting that this is a solution or in any way a perfect project in response to what I think are much bigger sort of systemic issues in terms of knowledge production in this field. But at least for me, it's been an interesting experiment in trying to sort of see what happens if we open up a little bit the space of ethnographic research and try to do things a bit differently. And to see how this has kind of challenged both some of the concepts that we were working with and some of the ways in which epidemic preparedness was being done at the district level in particular. So this project really started from our long-term discussions with colleagues at the DHMT that started during the West African Ebola outbreak when we were working on the Ebola vaccine trials and they were working directly in their response. And especially once Ebola subsided and they started thinking at the district level and at the national level a little bit more about what it meant to be prepared for future outbreaks, a lot of focus, unsurprisingly, ended up on vaccination. And in particular around a narrative that was really popular in Cambia, which is a border district on the northwestern border between Sierra Leone and Guinea. So a narrative that these particular borderland communities were particularly risky and they were at risk of experiencing future outbreaks because they were on the border and because they had low uptake of vaccination, or they had low vaccination coverage, which was assumed to be due to low uptake. And I put a question mark there because actually there was no evidence that this was the case. There hadn't been much research around what the reasons were for low vaccination coverage in that area that was leading to all kinds of outbreaks of measles and polio and so on. So not only did we not know why there was low vaccination coverage, but if we had some assumption that there was low uptake, we also didn't know why. And so this was the kind of question that the DHMT was asking themselves. But the fact that they didn't know what was going on, or that they were making assumptions that communities were most likely refusing vaccination, also meant that community engagement efforts to increase uptake were actually mismatched to realities on the ground, because there wasn't evidence about what communities' actual experiences had been, both in general and specifically after Ebola. And so this narrative just focused broadly on the specific challenges of borderlands, of people who in these border areas that potentially didn't feel part of Sierra Leone. They felt more Guineans than Sierra Leoneans, as some said. And so quite often quite top-down community engagement efforts that just kind of reproduce narratives from national level and messages that were sent from Freetown and so on. So colleagues at the DHMT felt that that was unsatisfactory, and they wanted to understand this issue more. And so what we decided to do together was to develop this pilot project, or this kind of exploratory project, let's say, to train some community health workers in some fairly introductory ethnographic methods, and get them to do research in their own communities and with their own communities, in specific communities on the Sierra Leone and Guinea border. And then the idea was that this research would then feed into some community engagement strategies that were then actually driven by evidence and listening to the communities, basically. And so the methods that the community health workers were trained in were sort of, basic qualitative research methods, interviews. They kept daily ethnographic diaries. They did focus group discussions, including with participatory methods like power mapping and rumor tracking, for example. Then once they'd done this research, we did a collective analysis workshop all together with the community health workers / community researchers, and with the DHMT, so public health officials at district level, so that they could also be involved in thinking about how some of those findings could then be translated into new strategies at the district level for trying to do, at this point in time specifically, community engagement around vaccination a little bit differently. And I'll talk you through some of the findings, and then also some of the strategies that they developed based on these findings and recommendations. And then also I'll talk a little bit about how then there were efforts driven by the DHMT and specifically by the district medical officer to try and actually integrate and make this kind of approach much more sustainable and sort of long-term, to integrate it over the long term into the district's epidemic preparedness and response strategy, for example, by setting up a social science pillar for the COVID-19 response in the last year or so. I'll talk you through some of the key findings, the most important findings, and specifically certain themes around what the community health workers found through their ethnographic notes and through their interviews, and about their own way of explaining what was happening in their communities around vaccines. So the first theme that we thought was really important and quite powerful actually was that people's explanations and descriptions of their engagement with vaccines, and in particular, was actually, maybe unsurprisingly, but I think it's important to point out, really deeply intertwined with their broader experience of what it's like to be a patient in a rural health clinic, for example, where are called peripheral health units. And this theme of sort of feeling disrespected, feeling humiliated, and feeling sort of mistreated to a large extent in these clinics was very directly linked up to then broader feelings towards vaccination, or maybe some reluctance to take part in vaccination drives. So for example, in some of the ethnographic notes from the community health workers, one wrote, one man raised a concern by saying that he sent his wife to the health center for his child to have the vaccine. When she arrived at the health center, the nurse told his wife, "Look how dirty you've come to the center." his wife almost wanted to cry because she's even older than the nurse. And there were many people at that time in the health center. So this is just kind of indicative of what really came up quite significantly in all of the research that the community health workers did around sort of these perceptions that rural communities, especially border communities, felt, what their experience was like of going to the health centers, and they felt that this meant that when then health workers would come to their villages, for example, to do vaccination, people would run to the bush or make their children go inside. These are some of the other sort of key themes that were identified in the collective analysis workshops. I'm not going to go through all of them, but I think maybe some of the most important ones for us, and the things I've found most interesting, sort of seeing the community health workers talk through them, was particularly around questions of power. So through doing power mapping workshops, for example, the community health workers, sort of turned ethnographers, were able to observe and then kind of bring this out into their ethnographic observations, how they themselves had been making assumptions about how power worked in their communities. And that meant that, for example, during vaccination drives, they often sort of decided to go to specific people who were official or formal authorities, let's say like chiefs, for example, or market leaders and so on. And the research that they did made them realize that having a formal position doesn't necessarily equate with being trusted or having authority, for example. And so they started sort of thinking and observing more about, informal networks of power, and the relationship between kind of formal and informal authority and patterns of trust, for example, and specifically in relation to health seeking and vaccination in particular. And a similar issue is around sort of a lot of assumptions that were made at the beginning by the community health workers themselves, and certainly by the public health officials that were part of the team, that they thought that that are a lot of rumors and misconceptions were going around vaccination. And actually what came out of the research was actually the opposite. Firstly, that awareness and acceptance of vaccines was quite high. But also that concerns were much more tied to kind of questions of mistrust and what I was saying earlier about kind of questions about the relationship and the nature of the relationship between healthcare workers and rural communities. And I think most importantly of all, the backdrop to all of this, and I guess hardest to then kind of act upon, but important to bear in mind, was the fact that there were really significant structural challenges, both in terms of, kind of systemic and long-term underfunding of the health sector that then kind of contributed to the lack of, the kinds of experiences that people in these rural areas were having in the health centers, and also more immediate structural challenges in terms of actual physical challenges of getting vaccines to people in these areas, for example. And I think that was important for everyone, including us and everyone in the team, to kind of remember that often when we think about vaccine hesitancy or vaccine confidence, we're often obscuring we're focusing on demand without thinking about, the supply issues. And I think that this was a really important thing to bear in mind when, especially in trying to kind of flip some of the assumptions that were being made about the role of community in epidemic preparedness and response. So I won't go through all of these, but what we did at the analysis workshops was to sort of take these themes and kind of try to kind of link them up to some practical strategies that could be put in place at the district level. And these were recommended by the community health workers after their research within their communities on the border. But I do want to focus very briefly on two strategies that were suggested by communities themselves or by the community health workers. And I want to focus on these strategies because they're very simple, but they, I think, at least for me, kind of showed what a difference it made to have opened up this space for ethnographic research, and to sort of think about what listening to people about their experiences of what it's like to live through an epidemic or to think about vaccination, and how this might help us do epidemic response differently. So the first was that in more than one community, there was a suggestion that they needed a peace meeting between communities and healthcare workers. And this was particularly interesting because at the meeting, the rules that were set, the ground rules that were set for the meetings, was that both community members and healthcare workers should put their experiences, their constraints, their frustrations on the table, And this meant that that whilst they couldn't really address or resolve many of the issues, because it was important, for example, for community members to be able to hear nurses for the first time tell them, look, I'm not paid, for example, or I work here as a volunteer. It's, I don't mean to mistreat you. I don't mean to take money from you if you come for vaccination, but these are also my experiences and what it's like to be a nurse in this part of Sierra Leone, for example. So I think there are a lot of issues to unpack around what that really means in practice, and we can do that in the discussion. But I think this was quite powerful or an interesting approach or an interesting experience for both the community, for the community health workers, for the nurses that participated in the meetings, and for community members who attended as well. The second strategy was to kind of think about how local concepts or concepts that were used specifically in this part of Sierra Leone to think about protection, like the concept of tama, which is sort of a Timni term for thinking about how one protects oneself from witchcraft, for example, through certain kinds of ceremonies, how those kinds of terms could be used to talk to people about vaccination or to talk about what protecting yourself might mean. And this meant that also it made, at least in the discussions and in the notes the community health workers took afterwards, it made community members feel like their own knowledge and their own experience was being sort of taken seriously and being taken as a starting point for having broader discussions about what vaccination is and what it means, and how their knowledge might be integrated and how we talk about them. I think a lot of these findings could have, of course, been found through traditional ethnographic methods, for example, but I think what was particularly interesting about this process was, first of all, the specific positionality of community health workers as ethnographers. So both their insider perspective, but also their efforts to go into their communities in what they called an empty cup. So kind of trying to kind of remove their preconceptions and prejudices and pre-assumptions about their communities and try to see their own communities from a new perspective, which of course was challenging as well. And we can talk about that in the questions if anyone's interested. But also how this meant that we weren't just kind of creating findings or identifying specific issues, but also that the community health workers, through their research, were questioning their own role and questioning how they had been doing how they'd been working within their communities as community health workers, or as in-betweens, I guess, or as mediators between the health system, the formal health system, and their communities. So, for example, this one health worker talked about how he felt that it changed his own work, because normally he would go to the chief and say, "Chief, the vaccine has come, let's go tell our people." But this research told me about the people I should really meet in my community, because they have a say, not the chief all the time. Maybe that man who sits in the corner who doesn't show up and you might not know he has influence on vaccination, he will be able to help us. And I also learned that we need to involve people in the communities in vaccination. It shouldn't just be us in the hospitals. So these were sort of some reflections from the community health workers about what it meant to them, or about how it made them think about their own role. So then this project, I mean, the research that we were doing on vaccination was ending in March 2020, and we all know what happened then. That the sort of question of epidemic preparedness and response kind of took on a new meaning and a new level across the world. And I think what was interesting, and again, to sort of think about how these kinds of, this community-led ethnography approach might go some way, I think not fully, but might go some way towards addressing the issue of how to integrate this kinds of perspective in the everyday functioning of epidemic preparedness and response. The DHMT, because they'd been directly involved in the project, they'd analyzed the data, they'd sat with the community health workers, they'd gone to listen to the communities when the research was going on, when the interface meetings were happening, and so on. They felt that they had ownership, let's say, of the project to some extent. And so they decided to take this up and continue and find funding to continue this project and to take it on into the COVID-19 response. And they decided to set up a social science pillar within their response. So we had the community health workers, the same 10 community health workers, continuing to do research on in these border areas about the experience of COVID-19. and kind of to think through, to help the DHMT and the district COVID response think about how they might use the very limited resources that they had at this time, very different from the Ebola response, to respond to COVID-19 at the community level. So I probably won't have, I don't have time, I don't think, to kind of go into much detail about some of the findings from the research that they did. But I think the sort of headlines were, again, sort of thinking about concerns and how concerns around COVID-19 and rumors as well were kind of much more indicative of mistrust and kind of broader questions about the role of their actually bigger questions about the relationship between communities, especially in these often marginalized rural border areas, and their health system. Of course, the sort of social dimensions of public health measures, the effect that this, the closure of borders, for example, or kind of intermittent lockdowns had on people's livelihoods, and the perception that's quite specific, I think, to Sierra Leone, where cases of COVID have remained so far quite low, that actually the economic threat of the public health measures was perceived to be much larger than the disease itself. And then sort of broadly kind of thinking about what the secondary impacts were of fears and concerns and mistrust around COVID-19, which meant that people started avoiding health centers, for example. So I just kind of briefly want to kind of think about what we've learned and what we are still learning. And I think that there are a lot of limitations, a lot of caveats to this kind of approach, but we have learned some important things about what it means to kind of to rethink about who produces ethnographic knowledge and how we can integrate these kinds of this form of knowledge for qualitative research more broadly into epidemic response and preparedness. And I think our substantive findings were interesting to some extent. So it was interesting and important, I think, to be able to identify the socioeconomic and political dimensions of vaccine confidence and vaccine deployment, and then later about COVID-19. It was important to be able to highlight the issue of trust, and also that trust in vaccines is not just about the vaccine itself, or in fact, I would say it's rarely about the vaccine at all. It's actually much more broadly about trust in the health system, or even trust in, about, say, society relations much more broadly. And, the importance of kind of respect and meaningful dialogue, whilst not ignoring or forgetting about the much, that talking to people isn't enough. It's important to have a baseline of respect, but it's also important to think about the kind of long-term structural issues. But for me personally, I think what's been the biggest lessons has actually been much more about process. And most important or most interesting component of this has been what a difference it's made to have, and I'm thinking specifically about if our interest or our end goal is about kind of making sure that these findings are somehow integrated in some meaningful way in epidemic response and preparedness measures, unsurprisingly, having community health workers and the DHMT directly involved in co-designing all the way from the project idea to data collection, data analysis, and write-up. Made a huge difference in how these were seen and accepted, and sort of the longevity of this kind of approach within the district approach. And I guess, I can talk a lot more about the challenges, but I think some are really specific, kind of pragmatic challenges. It was difficult, for example, in terms of literacy, to make sure that the different kinds of community health workers were involved. For example, we only had one female community health worker. And I think this can be addressed by being a bit more creative with research methods. Obviously, we had this was just an exploratory project, so we only tested it in the border areas and so on. But I think the much bigger challenges, of course, are the ones that I mentioned at the beginning about, the broader kind of systemic drivers of epistemic injustice, which kind of define who gets to produce knowledge and who doesn't in different spaces. But yeah, I think I'll leave it there for now, and hopefully this was probably quite a lot for a short period of time, but I just want to sort of put up a picture of all the community health workers that have been working on this, and I'm really happy to sort of discuss and have questions. Thank you.
Thank you very much, Luisa. Wow, very interesting. Most importantly, thinking about coming from West Africa, the issue of trust, rumors, among other things, and, the way people tend to run away when it's time, when it's vaccine, period. So all these misconceptions are really important, and it's interesting to me how you were able to navigate over some of these issues. And also, in terms of co-production of knowledge, I'm happy that you highlighted, the importance of working with people on ground when conducting research in areas like Africa, just so that it is not only maybe one person's voice that is being heard, but they also get to participate and be a part of the research. So I won't take too much of your time. So I'm opening the floor now for questions for Luisa.
A huge thank you to Luisa for this really powerful presentation of what seems to be an incredibly important and impressive project that you've been involved in, and what a powerful response from the African side. And I think we've seen the results of the experience, particularly in West Africa, and how that compares to some of the cases we've seen in Europe and in the West right now, faced with the pandemic and kind of the issues of trust and cultural barriers in the UK and in France, or in different contexts where rumours become particularly powerful, perhaps more so in France. And we see that with some of our colleagues who are working with the Algerian community in the UK, those who are very much connected to the French media are telling us more about these rumours, which are circulating much more widely in France than they are in the UK, and the kind of impact on BME communities in London. And so similarly with the test and trace system in the UK, which was very top down, national organised, big contracts, very expensive, but completely ignored the local communities and infrastructures that could have done it potentially so much better, and how that compares with the efforts that were made in West Africa. The question I had was can you tell us a little bit more about how the community health workers, the ethnographers, were actually recruited? Were they themselves distrustful, or were they already involved in this project, or working with the government, with the authorities? And could you perhaps just tell us a little bit more about your own involvement? What was your role in the project? You clearly know this incredibly well, so could you perhaps just give us a little bit more information about that? And thanks again.
Yeah, thanks. Yeah, there's a lot to say, I think, about what happened in the UK. And I think I won't focus on that because that's not your question, but I just wanted to say that I think what's really interesting, actually, I don't know if others have had different experiences, maybe in other places, but I found it quite interesting how little we learned from the West African experience, and then later from the Congolese experience, for example, with Ebola, in dealing with COVID here in the UK, for example, or anywhere else in Europe. And I think it's important to also note that knowledge was specifically not sought out, and that when it was offered, there was just, I think, a perception that's not the way that knowledge flows normally, right? That the UK can't and shouldn't, I guess, learn from other experience. And I think that there was a huge missed opportunity, especially at the beginning, as you say, because we had responses that were very clearly mismatched with people's experiences. I mean, if you think about, doing things like isolation without giving people any money for the work they were missing, for example, is exactly the same as what was happening in northern Sierra Leone during Ebola, when people were being quarantined with their farms going to waste, for example. So anyway, that's I think a whole other discussion. I should have said a bit more about kind of the actual specifics of the project. So I've been involved. So I've co-led this project with my colleagues at the DHMT. So we designed it together, got funding for it initially from the Sabin Vaccine Institute, and then we've been sort of pulling from wherever we can get a bit of funding to keep it going. So it's been going for the last year and a half or so. And the process of recruiting the community health workers was an interesting one, and actually one that I think has also then, at least for me, made me think about some of the lessons from this project, which was that the public health officials at the DHMT had some specific ideas about which were problem communities in terms of vaccination. And so they sort of decided to recruit community health workers that were associated with those problem communities. And I think that at the beginning of the project, when we did the training, we had kind of a flip chart where everybody should put their assumptions, I guess, going into the project. And there were a lot of assumptions that that I've mentioned about, what it mean, why these communities were thought to be problem communities, or what some of the drivers of vaccine hesitancy might be. And the research kind of flipped a lot of those assumptions around, even for the community health workers who came from those communities, and sort of, I think thought that they knew their community very well. So I think that's also quite an important, I guess, finding about the process. In terms of, I think some of the small thing I want to add in terms of the challenges with recruitment, as I've mentioned, I mean, one of the problems was around literacy as well. And there are, I think, sort of just over 100 community health workers in the district, but finding sort of, literate the community health workers wasn't easy. And I think that in the future, we've been thinking about how you might do it using voice notes, for example, or the ethnographic field notes don't have to be written, for example.
Thank you, Dr. Zainab. Thank you, everybody. And thank you, Luisa. Wonderful work, very, very, very pertinent work. Before my mind, I asked some question about your work and nowadays for pandemic COVID-19. What do you think about your research in front of COVID-19 nowadays? Because it is a very, very, very high interest to put your research in COVID-19 situation now in West African country. When I have COVID-19 in West African countries, they have many, many countries have hesitant, live with hesitant vaccination with against COVID-19 because they have many rumors in the major African major now. I think just this work can be contribute to drop out all rumor, to drop out all false information about COVID-19 vaccine.
Yeah, thank you. Yeah, it's a great question. It's something we're thinking about a lot at the moment. And I think it's such a complex issue at the moment, I think, for many reasons. I mean, the first one, which I think we have to kind of put on the table, is also the fact that countries like Sierra Leone have received some COVID vaccine, but I mean, compared to Western countries, I think the aim might be through the COVAX deployment, for example, to reach maybe at best 20% of the population, whilst Western countries are vaccinating their population several times over. So I think I'm just like a bit wary sometimes that we focus so much on confidence and hesitancy without kind of thinking about the fact that the supply is extremely limited as well, right? So I think that's kind of important to have that in mind. Having said that, absolutely. I mean, one of the things that's been coming up from our research with the community health workers that's been, and another research that we're doing as well, it's first of all, how interesting, well, in two ways, interesting how many of the kind of rumors and anxieties around COVID vaccines are very similar to the rumors and anxieties that we were hearing during Ebola about the Ebola vaccines, but also how much they're linked up, even in extremely rural areas of Sierra Leone, really linked up to and kind of tapped into kind of more global narratives around, the Gates Foundation and, microchips and all these kinds of things. So I think it's important to, I think it's an interesting area. I think just briefly, I guess that I would say that our approach to this has been to sort of try and contextualize these rumors and try to understand and emphasize how these, well, first of all, to try and kind of understand to what extent these rumors actually translate into refusal or rejection or even hesitancy of vaccine, because I think we make a lot of assumptions that there is a linear relationship, and that's not always the case also in Europe, I think. But also in kind of thinking about how we can get a bit deeper and kind of addressing the issues of trust that we were talking about, rather than, because I think a lot of the work that's been done at the moment is about debunking or kind of, offering different, better information, but that's not really kind of how, that's not really how it works even anywhere really, right? In terms of how people kind of make up their mind about these kinds of things. So it's not just that, you see a different kind of information, you suddenly think that that's, okay, I no longer believe what I believed before. And so to me, it goes back to that issue that I was discussing about power. One thing that worked really well, though not perfectly, but worked well during Ebola, was kind of really thinking about who do people trust at the very local level. So not who do people trust kind of generally, is, in each community thinking about, who are influential people who people listen to, and who people who have legitimate fears and concerns might listen to and talk to and feel kind of comforted by when they're expressing these anxieties.
Yes, thank you very much, Luisa, for giving us this window into what's going on the borders of Sierra Leone. And thank you very much, Mustafa, just now for your enthusiasm, which made me feel very much that this had been a good day too. My question is that you talked about the geographic constraints of the work that you've done, and the way in which you had been able to, with the 10 health workers you'd worked with, really win them over, and they had won you over to a particular way of working. And I just wondered, how did that particular district think that they could share their experience with other districts?
Yeah, thanks. That's such a good question, because it's been really on our minds as a team over the last few months. And it's, I think particularly the district medical officer, and this may be kind of specific to how the Sierra Leonean kind of decentralization works, but the district medical officer is in charge of sort of public health at the district level. And he's been a real sort of champion of this work. And I think, those are the kinds of things that I guess make a difference on whether a project works or otherwise. And I think we were also very lucky that we had these long-term relationships. So there is a lot of discussion in kind of social science for epidemic response at the moment about kind of rapid research. And I think it's possible and it's important to do it, but I think we were only able to do it because we had these kind of long-term relationships there already. So the district medical officer has been trying to kind of advocate for this to be expanded to other districts. And for example, there was a polio outbreak earlier this year across the country, and he'd been sort of sending our papers, our findings to the Ministry of Health and to the WHO. But yeah, I think it's been, so he's been advocating for it to be applied to other districts, and we've been sort of trying to get this kind of model of research tried elsewhere as well. But I think it's been difficult. I think that those challenges remain of making sure that people, especially in operational positions, kind of see the value of having this kind of evidence or this kind of research, and especially having qualitative insights. And I think it's interesting because with COVID-19, it seems like so many more people are interested in kind of thinking about rumors, about trust and so on. But I think somehow I feel, and I don't know if others agree, I feel that there is still kind of a bit of a missing link between kind of realizing that if we want to take those things seriously, then you also have to sort of listen to people and do the kind of groundwork, I guess, to understand where they come from. It's also a problem maybe specific to the epidemic response field, which is that it's kind of defined by urgency all the time. And so I think that there's often a perception that qualitative research is too slow. I think, first of all, there has been a lot of kind of rapidly generated research. There's also a lot of kind of pre-existing knowledge there, but also, I don't know, I think it's a risk, I think, to take, not to integrate this kind of perspectives.
Mine has to do with access, Luisa. How easy was it, navigating the ground there in Sierra Leone, especially with the local women?
Yeah, I mean, there are kind of so many layers of access to this project, in the sense that for me personally, I've been working in that district when this project started for about 5 years, so kind of in and out, and a bit longer than that in Sierra Leone. So I had the connections with the public health team, for example, and with kind of local researchers. But then what was really important was that the community health workers had this really specific kind of position within their own communities. And so their own role as researchers in their community gave them a kind of access that I could never have. In terms of, being kind of seen as, I think in Sierra Leone, but maybe elsewhere too, are known as kind of sons of the soil, so people who are really from the community and sort of seen as being insiders, I guess. I think that the gender question is more challenging. So there was one female community health worker that trained to be a researcher. And I think I mean, she did a great job and she really enjoyed it, but I think it was harder for her, and it's already harder for her, I think, to be a community health worker, which is a kind of male-dominated field anyway. And I think that also meant that because vaccination is often quite a gendered issue in itself, because we're often talking about childhood vaccination, which ends up often being kind of the responsibility of mothers, for example. I think there is I think there is an issue in terms of what the male community health worker researchers were able to access in terms of their ability to spend time with women and with mothers and kind of get their perspective, especially because they're insiders. So that's where the positionality is complex as well, because they're from the communities, they're known as kind of men in their communities. And so, yeah, so there's kind of so many layers in terms of kind of the different positions of different people in this project. And I think so I think the access was hard, but interesting to navigate in that way.
Thank you very much. Jess, do you have anything to add?
Just a really huge thank you to Luisa for sharing this really important research. And I hope that by sharing this presentation and the talk today, we can also some way chip away at the lack of flows of knowledge from Africa to the rest of us, because we can learn very much from what you've done there.
Thank you very much. Ladies and gentlemen, please join me in thanking Dr. Luisa Enria for this very interesting and thought-provoking paper and presentation. And like I said, please reach out. This environment is open to all. For those of us, working on Africa, feel free to reach out to either Jess or myself if you would like to present, so that we can have a chat on how to give you an opportunity to present during one of these seminars. Thank you so much. Thank you, Luisa.
Thank you so much. Thanks for
Thank
inviting me.